You did unmute. Share screen. Bring my other one so we have a spare. I think it didn't say recording in progress.
Do you need to sit between them, those two? Sure, I look at my book. What'd you do? Come look at my book. Does it have a bug in it? No. Oh. Did you already break it? Oh, yeah, mine did that. Did it? Yeah. I don't know why. I'm excited. My book is the definition of seen better days.
Just open it last.
That's a terrible idea.
You don't open it, it doesn't fall apart.
Yeah. I want that on there. I'm not gonna have to still, but.
Oh, we got
That's what I was gonna say.
For what?
Auto education.
Why is that?
make sure we're pause recording, stop recording. Okay, so it should be recording.
Actually,
I have a question.
Yeah,
The next time I do something, you turn my head across the floor and keep rubbing my back. Feels so good.
jerk your head.
You were very gentle.
Jerk.
They made everything pop from like the middle of my rib cage up.
I'm gonna get a lot of time.
What's 4 minutes? I asked you to do anything.
Oh, I got it.
I'm like, it's not talking to it, so.
Yeah.
Oh,
They have okay. They're there. Yeah. It's not.
Why is only Hannah on
That's weird. Yeah. Good point. Right.
so sorry.
It's not that hard.
Get all the technology. Fine.
Oh, this is just. It's just. Look it up.
If they're standing up. Oh.
They're laying on your hand. So like you put your hand in your.
There we go. Okay, there are two up there. Okay. Click burn. Now get you set up on that in just a minute. Just want to make sure we're good on this. Web video.
You look kind of body.
Ray USB audio device. Okay. Here. Test speaker. All right, speak. Okay, we're good. Hey, Hannah, can you hear us all right?
Yeah.
Okay, good.
Thank you.
Okay, we are recording. Okay. So now I gotta see if this will let me get rid of this naval content. Don't need to worry about backing it up right now.
Gwen's gonna see him to bring back money.
Gwen, I'm gonna start quoting you in class. I tell my dad all the time.
All right, Hannah, can you see the PowerPoints all right?
Yeah, I can.
All right, cool. Thanks.
Cool.
All right. So did you guys review stuff from last week? Primary, safety, that kind of stuff. You feel pretty comfortable with that when it comes to knowing mechanism of injury and resources? You get the gist of it anyway. And when does it start? Starts at dispatch information, right? So, and we're just gonna continue to build on that. So we went through primary assessment. If you have, I just want to review a little bit. So if you get on scene and you have, say MDC and someone hit their chest or complaining of difficulty breathing, and pretty soon they go unresponsive. Where do we need to go with that patient? Is that an emergent patient, not emergent?
Allergic.
Emergent, yes. And why is that?
Breathing issues, non-responsive.
Yes, unresponsive, and we've got an ABC issue. Remember, anytime we have an ABC issue, that's where we're at, okay? Unless they stop breathing, then it turns into what? Okay, so, your CPR, so, all right. I got too much stuff. We'll talk about secondary assessment, and then we'll break it down into the medical trauma patient, and then your detailed physical exam. Components, 3 categories of patients, and they just repeat the stuff, the medical trauma and an unknown. Okay, that ain't working. Oh, I gotta get really close. Okay. All right. Where's the, maybe it's just like, okay, I guess I have to stand here.
We're just putting batteries in that too.
Yeah,
I
it's just
just put new
something
batteries
funny
in it.
about it. Okay.
It was like,
All right, so we're gonna talk about the physical examination, your patient history of the present illness, and then your past medical history and vital signs. All right, so a sign is something that you see, think of a stop sign, yield sign, things that are visual when it comes to looking at a patient. You know, they're vomiting, that's obviously something physical. Pupil size, you've got unequal pupil size, that's something that you're seeing, those are signs. What is that?
jaundice.
Jaundice. Skin color, that's something you're seeing. What about this? Deformity. So you see an injury, so that again, that's a sign. Blood, bloody nose, and this is called pitting edema, pedal edema. You guys will learn about that later, but again, that's something that we actually visually see. Symptoms is something that the patient complains of. So they're nauseated, they have a headache, there's pain, there's pressure, it's radiating, visual disturbances, abdominal pain, discomfort. And then we reassess this stuff over and over again. But again, the difference between a sign and a symptom, just think of signs, and I taught this all the way up, is it's that visual. So a stop sign, yield sign, is something that you see, you can relate that to your patient. And a symptom is a complaint. Maybe. Okay. So your assessment varies depending on patient's ability to communicate. Responsive medical patient can answer history questions. Unresponsive obviously can't. Some of these are silly. Responsive medical patient, you're going to obtain a patient history, perform a physical exam, obtain baseline vital signs, and administer interventions and transport the patient. And we'll break this down. When a patient can talk to you, obviously you're going to get as much information as you can from the patient first, and then you can ask family or bystanders if patients unable to communicate, or maybe they're not with it. Maybe they're ANO ×2 or ANO number alert oriented. So maybe they're person place, but they're not really sure what time it is or date, and so they're kind of not quite with it. So you're gonna start asking other people if they witnessed something, or if it's a family member, if they, did they take their medications today? But you're gonna base these questions on chief complaint and then your observations, and ask open-ended questions. And we're gonna go on to samples. So what are examples of open-ended questions?
Questions that don't have a yes or no.
Right.
Not being.
So do you hurt? You don't want to ask that question. Do you hurt? No. Where do you hurt? Can you tell me? You know, those kind of things. So we want to be real careful about that. If they say, you know, yeah, I haven't been feeling good for a few days. Tell me more about that. Like, why aren't you feeling so good? You know, so try and get more information, because if you ask yes, no questions, they're going to answer yes, no. You're not going to get very far. Your sample mnemonic, like I said, these are the foundation of, you know, all the way up. Like I've been paramedic almost 30 years, and I use this stuff every time I touch a patient. So these are the patient assessment and your mnemonics that you're going to learn. You're going to use that for the rest of your career. So sample history, that's is for signs and symptoms. And so you're going to be looking at your patient. You're gonna look at skin color. Are they bleeding? Signs of injury, signs of respiratory distress. You can see if people are in pain. Listen to how the patient is answering your question. These are all observatory things that you're going to be, you know, checking boxes on where this patient's at. As far as transport, no transport, if you're gonna move on to your detailed assessments. And then signs of altered mental status, unable to complete sentences. Are they crying? Slurred speech, loud respirations, are they vomiting? Again, things that you're actually seeing. Symptoms. So S again, signs and symptoms. Symptoms, how and what is the patient feeling? They're nauseated, headache, depressed, pain, can't breathe, feels like, whatever. So again, it's what the patient is telling you. That's the why they call the 911. Is why they're feeling crappy, or you know, they're just having they haven't felt good in days, or they're having the worst headache of their life. Once you get that information, you're going to move on to your allergies. A is for allergies, so you're going to look for allergies to any medications, and I would ask what their reaction is. Do they have hives or a rash? Does it make them sick physically, mentally, or physically start puking, or do they get an anaphylaxis reaction? So that's the airway, the swelling of the airway, lips, mouth, that kind of stuff. So, and I was asked too when their last reaction was. Was this a childhood thing and they're 50 years old? Or is this something, you know, did they take a medication, you know, just a few weeks ago and had a reaction? So I like to get a good history about their allergies as well. What medications they're on. So I like to know what they're currently on, not only prescribed medications, but over-the-counter medications, as well as, depending on the situation, any other drug use. Did they borrow somebody else's prescriptions? Borrow. Maybe they fell and hurt their knee and they couldn't sleep, so they borrowed grandma's Percocet. And now they're having a reaction to it, but they don't want to admit it. You know, so did you borrow somebody else's medications because you didn't, you know, you didn't have that, or ibuprofen wasn't working, or whatever. So I try and get a good history of that. When we're on scene, usually you'll have if it's an older person, they'll have a bag of medications. And you know, it could be 2 bags. I don't know, but you may or may not get a good history on that, because they might stop taking like 5 or 6 of those, and they're just lumped into one bag. And so you have to kind of sort through. I'd like to get the history of what are you taking now? Did you recently come off any medications? Because again, you can have almost like a withdrawal symptom to some things, or your body's just, you know, transitioning to different medications. So that might explain some of the symptoms they're having. Your P is for past medical history. What have they been diagnosed by a doctor for any medical issues? You know, and sometimes they don't even know. They're like, oh, I have a breathing problem. What is that breathing problem? Why do you take this medication? And they might know the terms, they might not. So sometimes it's it's like checking by, like, nope, that's not it, that's not it. But they might come out with their COPD, they have emphysema. Ask if they have chest pain or if they're having an MI, have they had any in the past? Do they have any stints? Have they had, if you lift their shirt up and you go listen for lung sounds, do they have the zipper down there? So they've had open heart surgery. Sometimes they don't understand the medical language, so just keep it simple when you're asking those history questions. Do they have a history of chest pain? You ask people if they have angina, they're going to be like, I don't know what you're talking about. That's the medical term for chest pain, but most people don't understand the medical lingo. Again, history, diabetes, past surgeries, are they under the care of a physician for their current complaint or condition? They might have gone to urgent care for not feeling well, and then they call you back that night, and they might have been given an antibiotic or something, but it's making them feel they're worse. And so ask them if they've seen somebody, and who is their primary physician. The older you get, you seem to have multiple physicians. So you might have a cardiac doctor, one for their diabetes, and then they have their regular doctor. So they might give you a bunch of different names. But the more history you can gather, the better picture they're going to paint. You're going to paint for the doctors when you get to the ER, and the better care you're going to be able to give. The last oral intake is what and when do they eat last? Pretty easy. And events leading up to the event. Why are you there? What happened right before that? So what were they doing prior to the complaint or the ambulance call? Were they shoveling and now they have chest pain, or they're shoveling and they got back pain? Did they eat a handful of peanuts and now they're having an allergic reaction? That was obvious. The smoking, were they sleeping and the condition woke them out of a sleep? When people have chest pain in the middle of the night, I always ask that question, what were you doing because of the fact that this woke them up? That's pretty significant when it wakes them up. So sample you are going to use for the rest of your career. Just get used to asking those questions. And when you guys do your ride time, that's a good time for you to jump in. So you got somebody that's going to be following that, and they're going to jump in and help you out with that. So make sure you take the lead on this, and get a good history. So once you have your sample, you're going to go into you're going to kind of narrow that down even more. So just for instance, you got a patient that complains of chest pain. For pain, and you guys are going to go over this, I guess, tomorrow a little bit more. But we use the OPQRST, another little mnemonic, if you want to say, that we use. But O is for onset. So I want to know, again, what they were doing. Did it come suddenly or gradually? I'm talking about pain. Did it wake them up? What provoked it? Anything make it better or worse? If they're having a chest pain or a respiratory problem, take a deep breath. Does that make it worse? When they exhale, does that make it worse? Or does it stay steady? Quality, have them describe the pain. Is it sharp, dull, constant? Does it come and go? And if it comes and goes, again, how often is that? Is that like every 2 days it comes and goes? Or is it like, every half hour it just comes back? So again, it's trying to get your finger on what exactly is going on, and you have to it's like a funnel. You start here and you have to narrow it down to how you're going to treat your patient.
Click that. Click so.
Oh, okay.
Yeah, I think it's just Sarah.
I know.
It's not, but I mean.
All right, so your R is for radiates, does the pain spread to any other regions of the body, or do you feel pain anywhere else in your body? Again, try to keep it simple. Chest pain, a lot of people say, yeah, my chest hurts, but my neck feels funny, my left arm feels funny. Or females have weird symptoms. They might just say my back hurts, and it's like right here, or my right hand hurts. Females and diabetics have a little bit different presentation for chest pain. But just keep that in mind. So they might present differently, but don't rule out cardiac because they say their back hurts and it's not, and they look pale, cool, diaphoretic. You're seeing signs, but their symptoms don't align. Sometimes it's not going to be like that. In females and diabetics, your chest pains are not going to be like the book. So, so severity, that's your 0 to 10 or 1 to 10 scale. I don't care what number you use. I think the book was saying 0. You know, I've used 1 to 0 forever. 1 is the least pain that you've ever had. 10 is the most pain that you've ever had. Where's the pain on that scale? So that's
12.
where, what's that?
12.
Yeah, 12. and again, you look at your patient and yeah, they'll say, oh, it's a 12, and they're sitting there and they're smiling and joking, and I'm like, oh, okay. But, you know, again, it's their pain, it's their complaint. You mark what it is. I like the smiley faces better, but timing, how long does a patient have the pain? Is it getting worse, better, staying the same over a time? So that, again, you're funneling down to what exactly is the problem. Once you're done there, you're going to start with your physical exam. And again, if this is a chest pain, what are some things that we are looking at? What's the sign? Thank you. Your breathing. Yep. So we're going to start with our ABCs. Do they have an airway? Are they breathing? Are they, what's their skin color? So again, you're looking at your patient. So if they're a chest pain, we're going to go right to our, what is that pain, the OQRST, and then see if we need ALS to come with if you're a BLS service. And obviously your vitals and all those things. Are you going to go?
Baby test.
It's coming. Yeah. Baseline vitals. We have to get, you know, when we transport, we try to at least get 2 sets of vitals in on a patient because we want to get a baseline. From, I like to get them at the house where they feel more comfortable, and then in the rig as we go. But if you only get 1 set, you're not sure if your patient is their blood pressure getting higher, if it's getting lower, if they're, you know, what they're doing. So you want to make sure that you're reassessing your vital signs. Again, if they're unstable, you can do that every 5 to 10 minutes. If they're stable, it's about 15 minutes. So you're going to be rechecking that constantly. Luckily, we have machines that will do that for us, so we don't have to worry too much about that. Assessments of vital signs will be compared to baseline. So we'll be looking at that as you're going along. Like I said, your care might change due to your blood pressures or your pulses. You can take a manual blood pressure to verify accuracy. We run tests on our monitors in the morning, usually, to make sure they're working. So I see sometimes people use manual cuffs, sometimes they don't. A lot of traumas, I'll use a manual cuff, again, because I want to be able to feel where that pulse is at. And so if I just want a quick blood pressure, I'm just looking for that top number in the trauma. So remember, decision for prompt transportation of critical patients or those who, with specific complaints as part of the treatment plan. So again, you have a chest pain, you know, you only have 1 patient. So again, that dispatch information, I've got 1 patient I'm going to, it's a chest pain. So if I don't have a ALS ambulance service, I want to make sure ALS is coming. And then I want to get there and I want to start my initial assessment by looking at the patient when I walk in and getting your signs. You should have a good idea when you walk in the door, when you're looking at that person. Again, what's their skin color? Are they talking to you? Are they making sense? So when you walk up to them, you know, I'm Sarah in the ambulance. What, you know, you know, did you call 911 and why am I here? And have them explain, yeah, I'm having chest pain or whatever it is. And can you tell me more about that pain? Can you show me where that pain is at? So you're narrowing it down by those questions. And it could, like, once you take your vitals and they have, you know, blood pressure 120 over 80 and their pulse is in the 60s and like they look warm, pink and dry, but they're complaining of chest pain. Kind of takes your anxiety a little bit down or your stress down a little bit because you're like, okay, he looks stable to me. But if his blood pressure was 190 over 110 and they were pale and their pulse is bounding, like you feel it, it's just like boom, boom, you know, and he is, you know, like, what do we call this? When you have that chest pain, living, a little bit different. I mean, kind of ups your level of, okay, this guy's having a cardiac event most likely. So we need to get moved, you know, we need to let him go. So that Levin's, and then your primary assessment. You always start with your ABCs. If they don't have any ABCs, we go to CAB. And then this is ongoing. We're always checking your APU. So what's A? What's B? And P? And U? All right. How do we check for painful stimuli? So pediatrics, you guys will have a whole section on pediatrics, I'm sure. But pediatrics are a little bit different. When you approach these kiddos, depending on the age, if you have like say a toddler, you're trying to get down to their level. So if they're sitting on mom's lap or something, sit down next to the bed, kneel down, whatever you need to do to get kind of eye level. Don't hover over them. Obviously, stranger danger at that age, that toddler age. Always explain what you're doing with pediatrics. They might not have just keep it simple, very simple with them. Ask them if they'll show you their owie or whatever is hurting, or if they're not feeling good. Explain if you have to touch them, what you're going to be doing. And usually on pediatrics, we start with the feet first instead of the head. So you go backwards. And then, like I said, very simple language. And this is where your bystanders, your caregivers come in handy because you're not going to get a whole lot out of the kiddo. Takes a little bit for them to warm up to someone, but on top of it, if they're not feeling good or they're hurt, they're not, most likely not going to offer a lot of information to you. So again, that history that you're going to get is going to be from the caregiver. Where would you focus your physical exam on a patient complaining of shortness of breath? Okay. Yeah. I mean, why would you have shortness of breath? You're not able to catch your breath. You're not able to take a deep breath. You're not. So we could start with our chest, lungs, vitals to see if a circulatory problem, do they have enough oxygen in their system? Are they, you know, so yep. So on a shortness of breath, we're going to be looking at chest and lungs first. You know, we can start there. And then you know, you might not get your answer there. Maybe their lung sounds are clear, they're sat in 99%, but they just don't feel like they can get their breath. Okay, so is it a cardiac issue? And they think they just, you know, or anxiety, or, you know, there's a lot of other places you can go, but that's where we would start. So you start with your ABCs. Is there airway? What are we looking for? Patent. So is it open? Is it patent? They're breathing. What is their respiratory rate? And at that time, when you're first looking at them, do we care what that rate is? We want to know if it's what? too fast, too slow, or absent. So, that's your breathing and your circulation. What are we looking at there? Pulse rate. What about if you have good circulation of blood and oxygen, what should your skin be? Yeah. So that first few seconds of, like I said, coming in, maybe put your hand on the patient, you should have your ABCs done very, very quickly. From there, you go to your sample survey, and then again, this should tell you a lot about their circulation. Get your vitals, pulse oximeter, kept refilled. We'll come back to that. And when you're looking at your patient and they're sitting there, you're looking at their chest rise. Is it equal, shallow, deep, noisy? Again, we're not really necessarily counting at that point, but we're seeing if they're moving air. That's the biggest thing. And is that air noisy? Are you hearing anything? Are they breathing really fast or really slow, normal, or absent? And then we would listen to their lung sounds. And on this initial one, when I'm listening to lung sounds, if I'm there, I'm going to take a quick listen. I'll go back to that again later, but I want to check real quick. So I'll just probably listen to like 4 different areas of the lobes, and then I'll come back into detail and I'll fine tune that. But if it's a shortness of breath, and maybe that a history of asthma and hearing wheezing, do I really need to like spend a lot of time on the lungs when I'm already hearing it? I'm hearing the wheezing. So, then I'm going to move on and see what their oxygen level is. Do we need to get them on oxygen right now? Have they tried their inhaler? So like those kind of questions I'm going to be asking as part of that past medical or the OPQRST and your sample. So the medication part, I'm going to ask, if you have an inhaler, have you taken your inhaler? Have you gotten any relief from your inhaler? Do you have neb treatment, home neb treatments? Have you done a neb treatment? A lot of people that have asthma and they call 911, it's usually because they're anxious. They've tried using their inhaler and they just can't seem to calm themselves down to get that good breath in, to get the medication in. Or they've got a exasperation of their asthma, maybe they're got COVID on top of it, or something else is keying up their asthma. But a lot of people I've dealt with is just they panic because they can't get the medication down. And so when we get there, we get them on a neb treatment and they start clearing up. So that medication, yeah, I tried my inhaler 3 times. Okay, let's try it one more time and I'll walk you through that. You guys will learn that, but sometimes having that step by step, having someone else help them will help them get that medication in. All right, so your unresponsive medical patient, begin with the physical exam and baseline vital signs. Gather history from relatives or bystanders, do rapid assessment of entire body. What you gather, kind of, so if you've got let's do an 80-year-old female, lives with her son and daughter and grandkids and it's mom, and they went to check on her because usually she's up bright and early, and they go into the room and she's unresponsive. So they call 911 and they say she's unresponsive but breathing. We always hear that, but breathing. So you get there and she's laying in bed. She's unresponsive. She's pale, kind of cool to the touch. So you're asking, you obviously can't ask her questions because she's unresponsive. So what are some things you can do as you're walking through the house and in the bedroom? Is you can obviously have conversations with, when's the last time you've seen her? What time did you see her up last? Like, does she normally get up at 3 o'clock in the morning to go to the bathroom? Those type of questions. So you're going to start gathering that, but when you're looking around the room, what are you looking for? Yeah, Did she, does she have a cardiac history? And you look over and she's got her nitroglycerin sitting on the table. Did she have a respiratory COPD emphysema? And you can see that maybe she has her nebulizers in her hand, or her inhaler in her hand, or next to the bed. So when you're looking around like that, you can kind of gather some of that information just by your own observation. Because family, when that happens, they're in a panic, and so a lot of times they're not able to answer those questions. But you can be like, "Hey, I see she's got a nebulizer here. What kind of medications does she take, and just what kind of history does she have? Why does she take this medication?" Maybe center them a little bit to be able to help you out with gathering that information. Rapid assessment of entire body. If they're unresponsive, where do we start? Airway. Okay. So airway was Peyton. I said she was breathing, so we want to know what's next. Breathing. Again, is she breathing too fast, too slow? Is it absent, or is it normal? And then circulation. How are we checking that? Yep. Pulses. Skin. Is it pale? Is it pale? So she could be pale for different reasons, but that's just one thing up in your head, like, okay, and where did we find that pulse? So if she has a radial pulse, what do I know her blood pressure might be? About 90. So if you have a radial pulse, you at least have a blood pressure of 90. I'm talking about systolic. If I don't have a radial pulse, where's the next place to know it? Carotid. Lucky for you, she had a radial pulse. So you got a radial pulse, she's pale, she's unresponsive, and she's got a history of, let's do cardiac. So she's got a cardiac history. But then they're like, oh, and by the way, she's diabetic. So again, is there any other medications that she has that wouldn't be sitting out if she's diabetic? Insulin. So refrigerators is another place we need to check. So again, you've got to be doing, a lot of this is very helpful when law enforcement shows up and fire shows up. They can help with that while you're doing patient care. And relatives too. Can you go gather all her medications, please? And I usually send somebody with them. Because sometimes they'll be like, oh, I don't know if we need that. No, just put it all in the bag, we'll sort it out later. So your rapid assessment. So that's similar to the head to toe, but a little bit quicker. So we're gonna assess, this is swapped. They went from medical to trauma. Okay. Similar to head to toe in your trauma patient, only you're going to be looking for different things. Obviously, we're not looking for major bleeds, broken bones, that kind of stuff. I mean, you still do that automatically, but that's if it's a medical issue. We're going to start right there at the head. So she's pale, she's unresponsive. So I'm going to be looking, did she fall out of head and whack her head, or fall out of bed and whack her head on the floor, and then maybe she fell back into bed? I don't know. So I'm going to check and make sure that she doesn't have any bruising or trauma noted to her head. When I do that, you can check neck, chest, abdomen. So when we go through the neck, I'm going to see if she has any, stoma or trach. If she has any JVD, and we'll talk about that, I'll show you that. But and then trachea deviation. Some people get that with if they have a tension pneumothorax or collapsed lung. They could have it if they have fluid in a lung and it starts it starts pushing everything over. That's what happens. It starts pulling trachea off to the unaffected side. So you're looking at, is there anything out of the ordinary to the neck? chest, again, she's unresponsive, but she's breathing, so we can check for chest rise. See if both sides are rising together. And then we're gonna check lung sounds real quick. And then we're gonna move on to abdomen. And when we go to the abdomen, we're looking, is it distended and not like fat? People have carry extra weight there, but I'm looking to see if people have, oh, I know I have a picture of this, but not quite yet. The distension might be fluid, it might be air, but it's firm versus soft. Your abdomen should be soft. And so you're going to check real quick to see if it's soft and if she groans or grimaces the pain as you're touching in your 4 quadrants. And then pelvis, I'm looking to see if there's any bleeding, any incontinence, any fecal incontinence. So it's not just like you're looking for trauma because she's laying in bed. You still kind of got to look for that kind of stuff, but your focus is medical. So if she's been unresponsive, did she, not get out of bed and she peed herself? So urine incontinence. Extremities, I'm looking for circulation, one. So do I have pulses in all 4 extremities? I'm looking for that pedal edema, and we'll talk about that, fluid retention basically in those extremities. And again, she's unresponsive, so I can't like, can you wiggle your toes? Does anything hurt? You're not able to ask those questions. So you just got to visually look at everything. And again, when you go to move her, you're going to check her back. Again, so we always got to keep in the back of our mind, the trauma, the elderly, they fall. And so they could have fallen 3 days ago, and today they just didn't wake up because they had a slow head bleed. Or abuse situations. There's things that you're going to come across of that kind of crosses both boundaries of trauma and medical. So we're going to go through this again. Your neck is your jugular vein distension, medical bracelets or necklaces. You're going to check breath sounds, check abdomen for distension, firmness, or rigidity. Pelvis, incontinence of urine or feces, extremities, pulse, motor function, sensation, oxygen saturation, and any kind of medical devices on their wrist or ankle. Check for, your medical idea devices, your pupils. On your baseline vital signs, you're going to check for pulse, respiration, skin, pupils. When you're looking for pupils, I mean, you guys heard of I don't know if you guys read ahead, but we talked about pearls. Have you heard that term? No, it's not there yet. Okay. So you're looking for pupil size and if they react to light. So when we talk about checking pupils, that's what we're looking for. If you have one pupil that reacts and the other one doesn't, it could mean head injury. So again, you have somebody who's unresponsive, not able to answer those questions, and you see pupils that are, one is very large, the other one is very small. Again, it just, it could transfer over from medical to trauma. Every place you work has local protocols, so make sure you know those, go through them. Consider paramedics would benefit your patient. So if you have that patient that's unresponsive, maybe you're on a secondary crew and you don't have a paramedic or an intermediate, or no, sometimes we have that. So consider like, do I need a medic, or is this something that I can take care of with my BLS skills? And then consider the closest option for healthcare facility. So if I am in Glen Rock and I have a major trauma, where do I go? If I have somebody that fell and maybe fractured their arm and they request to come to Douglas, and Douglas can both actually run. So it depends on the day, right? But again, so you want to have that in mind as well. You know, for the Douglas folks over here, I mean, we just go to Douglas. So when you talk to a family member, what's the patient's name? Kind of important. So, and it comes to when you bring them to the ER and they want to look up medical records and see what their past medical history is, they want to know what the patient's name is. Obviously, what happened? Did you see anything? Did the patient complain before this happened? Does the patient have any known illnesses or problems? And is the patient taking any medication? So you're actually doing your sample, you're just asking the bystander for sample history. Looking for a mechanism of injury or signs that suggest a spinal injury. If needed, immobilize the patient's spine. Again, we have these kind of, they're talking about medical, but then they throw in trauma because it does cross the line sometimes. So if grandma stood up and got dizzy and fell over and now she complains of hip pain and neck pain. So what caused her to fall? The dizziness. So we have possibly a medical issue, but now we also have a trauma. So again, we might need to immobilize her neck or spine.
I think one of the big things we're talking about here too is a lot of times family members find their loved ones on the floor.
Yeah.
So we don't know how they got there.
No idea.
So
Yeah.
We're going to take that precaution and just make sure we immobilize them.
What other mechanisms might you have to obtain patient history other than speaking to bystanders? Again, we kind of talked about this. If you see bottles of medications around, you can look up the medications if you don't know what they are. You know, oh, this is whatever for high blood pressure. Okay. Oxygen, breathing equipment, nebulizers. Like I said, you look around their home or their rooms, and you're gonna get a lot of that history just by looking around. Again, your medical necklaces and bracelets, personal observations of where a patient is located. That, you know, to me is when we get those calls, maybe grandma's been down for a while. Again, has she maybe fallen and just can't get up herself, but she has peed and pooped numerous times. You know, she's been down there for a while, maybe. So again, where is she at or he at, and what's around them? You can always ask dispatch if there's been any recent medical calls pertaining to subject or address and what that call was for. And that's like maybe a mailman calls and says, you know, the mailbox is full. And I don't think anybody else lives here, but this elderly person, and you know, law enforcement gets there and they come in and, you know, she's on the floor, she needs medical attention, so they call us, but we don't have a lot to go on, and maybe she's not really sure what's going on. And so we've got to build from there. We don't have anybody to talk to. So when's the last time we were there? Most of these guys that work full-time here know our repeat addresses and usually know their first name and their grandsons and granddaughters' names. So they have a pretty good idea of their past medical history already. Medications, secondary assessment of the medical patient takes two forms depending on whether the patient is responsive or not. You assess the patient's, the responsive patient by obtaining a patient history, then performing a physical exam of affected parts of the body before getting baseline vitals. All right, so you walk in and the patient hasn't been feeling good for 2 or 3 days, not really mobile, let's say about 65 years old, history of CHF, cardiac, some other cardiac history, and takes a bunch of medications but really doesn't know what they are, just has them all lined out, you know, And so as you're looking at the patient, they're pale. You can hear kind of rattly breath sounds. As you're taking in, they're pale, their pulse is steady or really fast and like white when you try and find it. And then as you're looking at their head, their lips aren't blue, they're breathing okay. You don't see any trauma to them. You look at their neck, everything looks normal. Chest, like I said, you're hearing kind of rattly sounds. You listen real quick with your stethoscope, and you might have some wheezes in there too. Okay. And abdomen is soft, non-tender. You don't see that they've been incontinent, they haven't lost their bowels. And as you're looking down, you see that their feet are about this big, and they're complaining they can't get up because their feet hurt so bad. So as you're talking to them, that's like I said, you're doing the OPQRST. When did this start? Because they have a condition. Again, when did this get worse? You've got to narrow it down. So they've had CHF for 10 years. They've been dealing with this, but the last 3 days it's gotten really bad. Okay, so just because they live with a medical condition, they might have an issue with we've got to refine that to what has changed recently. Unresponsive medical patients can't communicate. Obviously, it's appropriate to start the assessment with a rapid physical exam. Baseline vitals can come next, then you interview the family, friends, bystanders to get any history that can be obtained. I think we've hit this one. It's like every other slide. So again, if they're unresponsive, they're not going to tell you what's wrong with them. So you've got to start with getting that quick assessment. Like Jim was saying, is this a family found them and you don't know how long they've been down or how they got down? Again, were they dizzy and fell down? Did they trip and fall and crack their head on something? So again, is this a trauma or is this a medical or something in between? And then narrow it down with your questions and what you get from your patients, families, friends. You might not change any field treatment as a result of the information gathered here, but the results of the assessment may be very important to the emergency room staff. Again, so if you've got an ABC issue, you're stuck at that ABC. We talked about that last week. So if their respiratory rate's very slow and you have to help them breathe throughout the transport, you might not get to anything further other than if somebody's riding with you and you're asking questions as you're going in. So it doesn't change your treatment because all you're doing is what? You're breathing for the patient. But when you get to the ER room, they're going to want to know, why is this person not, so they're going to want to know the questions. They have a history of asthma, COPD, emphysema. When did the difficulty breathing start? So that's why I said it's not going to change your treatment, but it'll change the treatment in the long run, or at least give them tools to treat them. All right, so secondary assessment of the trauma patient. Let's go back to our MCIs last week. So, or our crashes last week. So you go to a crash and, you have 2 patients. And you have resources come in, you called your scene, and we have a crash out on Highway 59. So what mechanism? High speed, and it's semi versus car. So you have mass. So which raises your level of possible injury. So again, remember that mechanism. All right, so we have a possible severe, just based on that information you get there, you have 2 patients. One is awake and oriented. And so one of you go to that patient, the other one goes to look for the second patient because they got ejected. So how serious? You've got high speed? You've got an ejection? Okay. If you've got an injection, or it was the driver, and it was let's do, they hit, semi was turning and they hit the back end of the semi. So your driver's ejected. What injuries are we, remember that?
Whole body.
Over, let's look at over or under. So they went over and they went through the windshield, so, yeah, full body. So just remember that over and under mechanism. So location of injury or injuries on patient, the one that's ejected, head, spine, chest, pelvis, femur, so yeah, full body. Mental status, so are they awake, alert? So this person's been ejected, they're not awake. So where are we going as far as that? So is this an emergent or not emergent? Emergent. Do you have the resources if it's you and another basic? No, so what else do you need? ALS. And if you don't have an ALS ambulance, possible flight maybe? Depending on where you're at. Okay, so this person is unresponsive and you get them moved into your ambulance. So we're gonna start where? We're gonna start here. So they're breathing, but their respiratory rate is 4. So they've got a patent airway, they're breathing, but it's very slow. Vital signs, you check a radial pulse and they don't have one. You obviously see that high mechanism of injury, and maybe the person is, let's go 20, and you don't know about pre-existing conditions because there's nobody telling you, but you're looking at them, looks relatively healthy, good weight, that kind of thing, but you don't really know. So if they're, you don't get a radial pulse, but you got a carotid pulse. So from there, we assess, focus on the area patient notes are painful or that the mechanism of injury indicates. So again, this is like a mass trauma. So you're just going to be going from head to toe. Like, you got to start somewhere. So we're going to start at that head. They're not going to be able to tell you their chief complaint, but they're unresponsive. So we're going to start at that head and we're going to be checking for any deformities, and we're going to go through DCAT, BTLS in here as well. None of you not, if you're going to remember for the rest of your life. But determine a chief complaint, again, is just they're unresponsive. This is a trauma and they're unresponsive. Conduct a history of present illness to gain information on how injury occurred. So you already seen that. They're at the MDC and they were ejected. So how about the other guy? So you've got one ambulance working on that guy, and then you got the passenger who had their seatbelt on. And they're complaining of their chest hurts. They've got some, my arm hurts. Remember that passenger, what do they usually do? When they come up, they brace. So, their arms hurt, their chest hurts, maybe they bumped their head, but they're alert and orient ×3. Their skin is warm, pink, and dry. They are telling you, yeah, I'm 22 years old and I don't have any medical problems. I'm pretty healthy guy. Okay, so kind of gives you that that little bit of, okay, is this a stable or unstable patient at this point? No, they're warm, pink, dry, they're alert and oriented, they're telling you what's going on, they're telling you about their chief complaint, and they're answering questions appropriately. So you want to conduct a history of present trauma or injury. So my arms hurt, and so we can focus more on their arms versus their full body. His chest was hurting. We can take a look at the chest. Look at that. Is he's got a seatbelt, red mark from the seatbelt. But other than that, he's breathing fine, feels fine. So it kind of, again, you have one story to the other, and it just usually doesn't happen usually when there's trauma. I'm just kind of creating that and the difference there. So you're going to narrow down to gain that information. Is there more, I have chest pain from the seatbelt and I have my arms hurt from putting it up and hitting the dash. And then you can focus on that area versus doing a full head to toe. You're still going to come back and you're going to check them over because again, if you have somebody who broke their arm, but they also fell, that pain in their arm is going to kind of distract them from other injuries. So we're always going to go back and look at that. But for the initial, we're going to look at the patient, ask what their chief complaint is, and take a look at that first, and then go back and do another assessment. The patient history, again, nature of force involved, direction and strength of force, protective equipment used by patient, actions taken to prevent or minimize injury, areas of pain and injury resulting from incident. When we talked about falls last week, so you've got a guy that fell off a roof. So do you remember what the height was? When we talked about significance? What's that? What? Okay, so 2 to 3 times the height of the person. So when you're looking at a fall, what did they fall from and how high it is and what were some other things? What did they land on? Anything obstruct to it, yep. So they bounce off things as they came down. So direction of and strength of force, did someone shove them off the roof? Or did they trip and fall, they slide? Did they hang off the roof and then jump? So obviously direction is gravity there, but protective equipment used by patient. Maybe they just had a hard hat on. Did that really play into their what their injury was? If they're roofing, they're not going to feel like if they got a shirt on. So maybe they don't have any protective equipment. Actions taken to prevent or minimize injury. They don't really have any when they fall off that. But areas of pain and injury resulting from the incident. Again, you can ask how they landed, or if someone's seen them, how did they land? The guy might say, I fell off a ladder and I landed on my feet, and then crumpled from there. So we have that impact from, feet all the way up. Did they land on their side? And they're complaining of neck pain and shoulder and side pain. So, again, it's looking at the scene, making decisions from as you're approaching and gaining information from people around you, what the person is dressed in or protective equipment. And if they're able to talk to you and tell you their areas of pain. Areas assessed depend on injuries and chief complaint. Again, it's that, fell down and my arm hurts. They tripped and fell. So, they're just complaining of their arm hurting. So we're going to narrow in and we're going to just look at that arm or chief complaint. Mechanism of injury may point to potential injuries. 3 techniques: observation, palpation, and auscultation. So mechanism of injury, again, we keep going back to that, but if someone trips and falls, just from walking is different than, again, that shoving off the roof. There's a huge difference in that mechanism. So if you have somebody fall off the roof and they're just complaining of ankle pain because they landed on that foot, and maybe, again, we get focused because that ankle is extremely deformed and like, oh, there's that big injury that we all like to look at. But we're not paying attention to what happens when you land on an impact. From an impact, where does that energy go? It goes up. So there's potential there for other injuries. So yeah, there's potential for more injuries, but the patient just knows that that ankle hurts and their foot is like flipped out to the side because it's dislocated. So they get stuck on that. We get there, we're looking at that, but we have to remember that the mechanism, there could be more injuries. We've got to make sure that we do that assessment. And so again, everything starts with what we see, and then we start examining the patient on what we feel, and then also what we hear, and that's by auscultation. So observe for abnormalities in symmetry, color, shape, and movement. All right, so anytime like I got somebody who's complaining of maybe shoulder pain, just very low mechanism of injury, I'm gonna have them, I want to have them squeeze my hands to see if I've got one weaker than the other. Color, I'm looking for, do I have circulation in both, are they pink, both hands pink? So I'm looking for cap refill. Shape, do I have a bone protruding somewhere? Do I have a dislocation? Do I have a deformity? And movement, are they guarded? Do they not want to move that shoulder? Or, you know, are they limited on their movement? And I'm going to check that other arm. So you're looking at both arms versus just examining one. You're always going to compare the second one because previous injuries can limit movement. So, you know, this might be something that is new or old. So again, we're going to be asking those questions as well. But symmetry, you want to check both sides. Palpate for abnormalities in shape, temperature, texture, and sensation. So this is where you're feeling for those. Deformities in your bones or joints, the temperature of the skin. You know, if they have like a compression type injury or something, you know, like maybe something lands on their arm and you remove it and this part of the arm is cold, this is warm. I want to know that. Or is the whole appendage cold? Maybe they have a dislocated shoulder and the whole arm is cold to the touch. The texture, texture of the skin, texture of the injury that you're feeling. Is there crepitus? Is there, you know, squishy? Is there, does it feel squishy? That's fluid. So, you know, you're looking for those type of things. Again, it's what you are feeling. And then is the person, do they have sensation when you're feeling their skin? So most people should be able to feel you touching their hand, touching their toe, touching the side of their leg. Spinal injuries, we're always looking for, you know, someone's got a significant fall and they're complaining of back pain. You know, I'm going to be checking if they've got sensation on their toes, sides of their legs, back of their legs, arms, hands. As we go down the road for 45 minutes, that's something I'm going to be reassessing constantly because as we're hitting bumps, that could change. Or inflammation. So they've got an injury, so all of a sudden now they've got swelling and now they've lost that sensation. So we want to be constantly monitoring those type of situations. And I had one guy who had been electrocuted, who went to, he's a lineman, young, brand new, went to go put a wire, and the other guy didn't shut the power down in time, so he cut the wire, and it blew off half of his arm. And then he had fallen out of the cherry picker basically and was hanging by his harness. And so when we got to him, he had just started getting responsiveness, and he had obviously this was a gross injury, like, we're like, whoa, you know? But he also had electrocutions, so he had internal injuries, but then he also had a spinal injury. So we had a lot going on with him. But as we were driving down the road, he was losing feeling in his legs. So he had sensation when we first got there, but we had I think it was 35-40 minute transport, and we were out of Gillette. And so by the time we got there, you know, I just started marking in timing. I took a Sharpie and I was marking where he last had his sensation and a time on there. So again, that reevaluation of a patient is extremely important. Obviously, when we're listening for breath sounds, we're looking for, are they absent on one side? Are they absent in part of the lobe? So your lobes come down. And so maybe the upper lobes, you've got air movement, but the lower lobes, you're not hearing any air moving. Or, you know, are they decreased on one side versus not, you know, you have normal sounds on the other. So we're listening for, is it normal? If it's not, what are you hearing? Or what are you not hearing? Maybe.
Just so you know, it's not you.
Pretty sure it is. So I was telling you earlier about DCAP BTLS. This is another one you will never forget as you're using it. So when you're doing your head to toe, this is what you're looking for in a trauma patient. So DCAP BTLS, you're looking for number one, deformities. So if you've got a trauma, you've got especially your high mechanisms and maybe an unresponsive patient, you've got to know the story. So you've got to find the injury. So, but you're going to go along, you're going to start at the head. On an adult, we start the head. Remember, pediatrics, we start at the feet. So head, we're going to run your hands over. You're looking for any major bleeds, any deformities. So we're just checking here. Any skull movement. You're looking for contusions. So we'll talk about battle signs in a bit. And any abrasions, punctures, penetrations, burns, tetanus, lacerations, and swelling. So you're looking for all these things at every part of the body. So you can start at the head, and you're feeling and you're palpating, feeling for any of these. And we're going to go ears, face, mouth, neck, chest. So we just go down the body, and you're looking for this every time you touch a patient. So your deformities is what?
Broken stuff.
Broken stuff. Yeah. So it could be a joint, it could be a bone, but you know that you're looking for that. Contusions, what are contusions? Bruises. Abrasions, scrapes, punctures and penetrations, holes. Burns. Tenderness is just pain. Lacerations and swelling. So early vital signs provide snapshot of stability. Vital signs provide baseline for future assessment. Again, getting that first set of vitals and repeating them kind of shows the trend of your patient's stability. If your blood pressure starts dropping significantly, pulse starts raising, we're looking, you know, why is this patient, trauma patient's blood pressure doing this and pulse doing this? Well, do we have a bleed somewhere that we're not seeing? Are they going into shock? Is their blood pressure, you know, hasn't moved the whole time, and they're talking and alert and oriented and not really complaining of a whole lot? Do we have a stable patient? So vital signs are extremely important when you're transporting patients. Applying a cervical collar to any patient who requires spinal precautions. Cervical spine immobilization device should be rigid and make sure they're right size. So again, this is for that maybe that elderly lady that fell. Again, go back to your mechanism. Why are you there? What were you called for? And then is this patient a trauma patient and a medical patient, or vice versa? And are they complaining of neck pain? You guys have a full spinal section on, so
I think it kind of goes over the measuring of it here, but we'll go over more of it
Okay.
during spinal mobilization.
Have. So complete the primary assessment and care for life-threatening problems before applying the collar. So that's what you start your head to toe. You're going to do the head first. You're going to look at the neck for any trauma or any issues. You're looking for that jugular vein distension. You're looking for the trach deviation, and you're going to check the neck. You're just going to palpate back there, see if you feel any of that DCAT, DTLS, any deformities, confusions, abrasions, bleeding, whatnot, and before you put the collar on. Because once the collar is on, we don't take it off. The doctors will take it off, but we don't. So you've got to be able to assess that before you put it on, so you can let them know, and you don't miss like the major laceration back there or deformity. You'll never forget that again.
Which one was it?
If you put a collar on and you didn't assess.
Oh,
Yeah.
that.
Yeah. We'll go over those. So you're gonna size your collar. We'll talk about that here in a minute. Remove jewelry and move hair. Keep patient's head in the inline anatomical position. Again, nose, belly button, and toes all pointing in the same direction. Explain that to the patient. I'm gonna hold your head still. Because you complained of neck pain, you want to make sure I don't have X-ray vision. We want to make sure that your neck is not moving. And so we're going to keep your head still. And so when I tell patients that, it gives them something to think about. Nose, belly button, toes, so it gives them a little bit something to think about while you're working on holding C-spine and getting your collar measured. So your collar is going to get measured from basically your chin line right here, the end of your ear to your shoulder, the trap. And then how to collar, but you go to your collar and you're gonna measure, is it 3 fingers, 4 fingers, or maybe it's bigger than that, but you're gonna pre-measure your collar and then you would put it on. And like I said, you guys have a whole section on spinal mobilization and
Yeah, they've got like 4 or 5 days of nothing but trauma.
yeah,
Yeah.
so I'm not gonna spend tons of time on that, so.
I've got like 20 years on trauma. Not the mental trauma, honey. Oh, yeah, that's one
Never mind,
my
yeah.
class.
Waking up in the morning isn't trauma.
2 people got shot in my front yard. Don't talk to me about trauma.
I grew up in Chicago.
We're done.
That was a year ago.
You're why she has trauma. And you're the reason she has trauma.
So if you've got somebody that you have decided to take C-spine on, guess what? That's where you're at. Until either your mechanism your boarding takes over, or you're gonna be holding C-spine. So and again, looking at the mechanism, looking at your patient complaint and the signs and symptoms your patient's giving you, is this a ALS patient or is this something that could be transported by BLS? And then you're going to perform that rapid trauma assessment, complete head to toe assessment. So when you're, so we'll go back to this one. So you go to a car crash, it's a 40-mile-an-hour rear end collision. And the driver had her seatbelt on, but she's complaining of neck pain. What can you tell me about that patient right now? Possible whiplash, but go to your, what's the mechanism? 35 and above. Yep, that was from last week. Yep, so what else? If she tell you, so what is her airway? Gate airway. So if she's just having that, all right, I was driving and I got rear-ended and had my seatbelt on. I was going to school to pick up my kid. So what are you thinking her mentation's at? Yep, I mean,
What's gonna happen?
so she knows what happened, so she knows what she's alert and oriented. And the events, place, time, pretty much. You could say, well, she's going to pick up her kid at 6 o'clock in the afternoon. Yep, okay. And you obviously would ask for her name, but so you've already, without even touching her, you already have some kind of baseline, right? So she says she's complaining of neck pain, so we're gonna take C-spine. So someone is gonna have to go back there and hold C-spine, and that's where they're at. So we go. All right, so you're holding C-spine, you get her measured, and then she's got earrings in and like long dangly ones and a necklace. We gotta get that stuff off. Hair is a pain in the butt when you try to put these collars on, and Velcro sticks to everything but Velcro. So you're gonna be fighting with that. So that person in the back seat is gonna be doing these type of things, trying to get hair and jewelry and, making sure that head stays still. But as they're trying to get that collar on, and like I said, that person in the back seat, that's their job, is to hold that head still. Once the collar's on, you're still holding C-spine. You hold that until you get the patient out of the vehicle onto a backboard, and then they're taped down to the backboard and their head's taped down, and then you can let go. Again, that 35 mile an hour and above, we talked about the injury pattern on that. So it is considered significant. I know in our minds, 35, when we've seen crashes at 90 miles an hour versus 35. Again, the 35 mile an hour ones can bite you in the butt if you don't treat the patient and their complaint for what, so don't rule out those lower mile per hour crashes. So we get them into the back of the ambulance, and we'll start our rapid trauma assessment. So we're just gonna do our head to toe real quick. As you're feeling, you're not feeling, your decap BTLS is pretty low. I mean, or pretty normal. She's not complaining, you're not seeing anything, you're not seeing any deformities, contusions, abrasions. She's not bleeding anywhere. She has a little bit of tenderness in her spine. I would say T6 through like T4. So that going forward, that, what do we call that? That whole whiplash type thing. So she's complaining of a little bit of pain there, but you're not seeing anything on the outside. Consider hidden injuries. So when we talked about speed, so vehicle's going 35 mile an hour, comes to a sudden stop. What's that body going? 35 miles an hour. So what are the organs doing? Going 35 miles an hour until that sudden stop. So boom, that hits, and then what happens? They come back. So then what happens with the person? Person slips back maybe in the seat a little bit, and then what happens with the organs? They slam back too. So hidden injuries, any kind of trauma, look for that's that reassessment. So if they start, you're traveling, you get them in the ambulance, you get them a quick assessment, and you're not seeing a whole lot. She's complaining of that neck pain. And about 10 minutes into the ride, she's like, oh, gosh, it just kind of hurts a little bit. So what do? We need to go back and reassess that, right? So we're gonna go back, we're gonna look, seatbelt injuries common, so they're gonna have that, they could have that red mark, or they might not have a red mark, but that slamming of the organs inside, we might have hidden injuries that we're just not seeing physical signs for, but she's complaining of those things. So airbag injuries, again, is another one. If you've never seen them come out, that's very violent when they pop out. They could cause inhalation injuries because they are inhaling that the powder. So it could be an irritant, as I should say, to their lungs. So they could be coughing up that. If they have asthma, that could exacerbate an asthma attack. Steering wheel injuries. Again, it's that chest and abdomen hitting the steering wheel. You might not necessarily see, you're not gonna see bruising right away. You might see a little redness, but again, you might not see anything and yet they're complaining of something. So just think about that mechanism of the speed and the sudden stop of what it happens to the body. I was looking through this today and I was like, just kind of keeps going back and forth. On that kind of situation, again, you can look at, do you need ALS? What your local protocols are going to say, and familiarize with types of patient local clinics can help. When I was stationed in Wright, I was there for about 2 years and we had a clinic there. And so I always called that doc if it was something pretty low key. Like if it was, because they could do x-rays, they could do blood draws. So I knew what their capabilities were. And we had some patients that really didn't want to go to Gillette. And so I called the clinic and asked them, hey, would you mind seeing this patient? And we would go pick them up, bring them to the clinic. And so, I mean, there are places throughout the state with that don't have a hospital. I know Sundance for a long time just had a clinic. I think now they have a hospital, but again, that, you know, they were kind of like a urgent care. So there are places that will take 911 patients or ambulance patients. You just got to have that relationship formed beforehand. Rapid trauma assessment requires only a few moments, should be performed at scene. Care provided en route would be based on the assessment. Again, these assessments, you're just looking for anything major. So you're looking, you know, for that DCAT BTLS, and it is a quick sweep. This isn't where you're looking in ears and up noses, and you are just looking for anything that is, you know, they're complaining of arm pain, and so you're looking for that injury. Like, is there a deformity? Is there major bleeding? Nope, I'm moving on. Even at that point, I'm not going to splint. Yep, this feels broken. Okay, I'm going to move on because that's not a life threat. I want to make sure that we go and cover everything, and then I'll come back to that. So that rapid assessment is just looking for anything life-threatening, and then we're going to go back and assess again. Rapid assessment of the head is rapid assessment of the head. Again, you're palpating, looking at the face, ears, nose. You're just looking real quick, blood or clear fluid. Is there anything coming out of, is there any discharge? If it's not blood and it's clear fluid and you're looking at a possible head injury, we call that it's CSF that could potentially be leaking out. What we look for on, like, if you've got a head injury, they have fluid leaking out of their ear and it's kind of clear, maybe pink, and you get some on a 4x4, it creates a halo effect because it's cerebral spinal fluid and blood. So it's kind of a mixture of that. And so your cerebral, I put a picture in here. I'll come back to that, but I think actually this. All right, so I don't know where that picture went. It was, I think, right there. But so any kind of fluid, just suspect that it might be cerebral spinal fluid leaking out. And if you see battle signs are they're black eyes and then some redness behind the ear. Almost looks like real bright purple. So when I talk about battle signs, it's basically, it's after some dude who's named after, I can't even think of the guy's name, but he's the one that founded it. But so what it is they're 2 to 3 fractures within the skull. And the cerebral spinal fluid starts leaking out of those fractures, and it starts settling. Right behind the ear and then around your eyes, because you have openings around there that the fluid kind of drains to. I've only seen this probably twice in my career. And one of them, I think they had 3 different fractures. It was a pretty bad basilar skull fracture, but they had 3 different fractures. And this is pretty prominent. Like, it doesn't look like someone, punched them and they got a black eye. They're swollen and they're bright red, like that, bright red purple. And then you see that, and it's pretty instant. So if you see those type of things, just, put in the back of your mind, I've got probable skull fracture. You're checking the neck. Again, you're looking for any soft tissue damage, injury, or to the major vessels. If you've got a tracheostomy, again, if they've got one of those, that means that they've had either some kind of issue with their upper airway, whether it be cancer, whether it be some kind of obstruction, a tumor, or something has caused them to be able to not breathe normally. So they've done they were drained in trachea here, and they're not able to move air appropriately from their upper airway. So that's why they have those. There's a whole, just mark that, like, yep, they've got a tracheostomy. It seems like air's moving okay through that. But you're not going to spend, if you've never seen one, you're going to be like, oh God, what do I do with that? But if everything looks normal and they're moving air out of there, don't worry about it. It's when they get clogged, when they start having sputum, nasty stuff coming out of it, or blood, that's where we start worrying. JVD is when your jugular veins get distended. Haven't seen this maybe 6 times in my career. This is pretty significant. But basically what it is the pressure is building back up, and it's building the blood back up into your jugulars, the pressure from your cardiac system. So again, it's just for you to know, because if this is a neck injury and you put a collar on, you're not going to be able to see that. So that's why that neck exam is very important. But again, it's a backup of the blood from the superior vena cava. And there could be a bunch of different reasons why, but just look to see if you see that. Trachea midline are shifted. So again, we talked about this earlier, that tension pneumothorax, which is a collapsed lung, or blood in the chest. There could be a tumor. Something is pushing the trachea the other way. So what usually happens is, so as we're sitting here, the air pressure in this room is a positive air pressure. In our lung space, we have this little space in here, this little space. It's a negative pressure system. If there's a puncture into that lung, or they have spontaneous pneumothorax, but usually if they have a puncture, say a stabbing or a gunshot wound, now that positive air pressure is going into a negative space. So when they take a deep breath in, through the puncture, the air actually comes in and comes into that negative space. And what it does is it starts collapsing the lung. And so that's what a collapsed lung from a pneumothorax is. So it's gonna keep collapsing because that positive air pressure starts building up in that lung space, and that lung has nowhere to go. It's not able to inflate. So what happens eventually is that positive air pressure becomes too much, and it starts pushing the mediastinum or the heart over to the unaffected side. So you start seeing that, and then all of a sudden the trachea starts shifting. Usually, like if we see this as it's like this isn't something like we're there in 5 minutes and we shouldn't see this. This is a later sign, but it's something that you hopefully won't see. But what we do with this is you got an ALS unit and we dart the chest, and what that does is we cover up the injury. So if they've got a through and through gunshot wound, we're gonna stick our hand over that, both sides. Hopefully we have a chest seal, maybe we can use a chest seal. But basically what we're gonna do is allow a mechanism for this air here to come out back out of their chest. So if we dart their chest, we stick a needle in their chest, we're gonna get that positive air pressure back out, this here. And then we should have a valve on the end, so we can shut that off. So that when they go ahead and take a deep breath, it's now coming back in through their mouth down here instead of getting sucked in whatever wound. So we're gonna cover that up. But that trach deviation, again, if you're on a long transport, especially we got a wreck way up north or south or wherever, and we have a long transport, and they're complaining of difficulty breathing, maybe they're not completing their sentences because they can't get a good breath. And you're starting to look and you're like, oh, their trachea is shifting a little bit. And so again, it's something that we would reevaluate, and for ALS, we would intervene in that. For you guys, you need a medic, you need ALS, or you need throttle therapy. So that's just what you call it, your gas pedal. But other things can do this too. So pleural effusion, so somebody's got a nasty infection in a lung and it fills up with fluid, it could be the same thing. Some of the things that I think scarred me from paramedic school was going in while they drain the effusions out of people's lungs. You're like, oh my God, what is in it? Like liters of fluid coming out of people's chests. And it's infection, so it's goopy, nasty stuff. But yeah, so fluids can do that. Blood can do that. And then also, if they have a tumor, so you might see that if you have somebody who has, a cancer or a tumor in their chest, and it has put pressure on and pushed their mediastinum and their trachea over. All right, C-collar, again, you're going to size it appropriately. And once you hold C-spine, you're there. Now, protocols have changed over the years. We talked about that last week. Everybody got backboarded when I started this business. Like, he fell down, he got backboarded. If you even mention neck pain, you go backboarded. Now we we look at that mechanism. We look at our patient. Are they stable? And we assess our patient to see what kind of injury they have. Do they have any of those BCAT, BTLS? And go from there. So we might put a collar on them, and then we don't backboard them. We don't hold C-spine. It's very low mechanism of injury. They just complain of neck injury or neck pain. New protocols are coming out. That's what we do now. So it depends on your protocol wherever you guys end up working. So make sure you know that before you hit the street. Make sure you know your protocols. Your rapid chest assessment. So again, we're looking at the chest. Is that chest, when you take a deep breath, your chest should have equal rise to it. Do you have a paradoxal motion, which means you have a 3 or more ribs broken in 2 places, and you get kind of this floating rib area? So what happens when you take a deep breath? Everything expands, but then when you exhale, that chunk that's broken is going to sit up. It's still going to stay up instead of coming in with the chest. So you have what they call a flail segment. So you're looking, especially, like I said, we're talking about trauma here. So if you have one, or if you have chest rise on one side and not the other, so you're just looking, is their chest rise equal? And if not, what is that? Is it a section? Is it the full chest or full side of the chest? What's going on? Crepitus. So again, as they're taking a deep breath, you know, in your feeling, you actually put their hands on their chest and you're feeling that. Do you feel bones grating? Do you feel, you know, any kind of fluid? Sometimes you can feel fluid in there. So the crepitus, what are you feeling when you get your hands on their chest, they're taking that deep breath. And then obviously your breath sounds. Rib cage and chest must be exposed. So again, in trauma, you know, we get their clothes off because we've got to see what's going on. Just inspect and palpate for wounds, tendons, yeah. So you go through your DCAT, UTLS, and again, visual as well as palpation and auscultation. We're going to go back to chest. We're osculating for breath sounds. So I like to go left, you know, I pick a side and I compare lungs. So if I'm gonna check the right side up here, I'm gonna go to my left side and go down. And I check the bases through under the armpits and in the auxiliary area. But again, you're gonna be checking each sound. Lung sounds are easy to hear from their back. And the reason behind that is if you've got somebody who has a large muscle mass or maybe large chested as a female or carries extra weight in their belly or they're just obese in general, sometimes it's hard to hear through that. So if you're having difficulties and maybe you're log rolling them to get them on the back road or whatever, take a second and listen to lung sounds in the back if they're not able to hear them in the chest. Your abdomen, so you've done your chest. Now we're going to our abdomen. Again, we're looking for that distension. And we're looking and feeling for any pulsating masses. What that usually is, if you've got a pulsating mass that sits right about here, is usually not a good thing. It's called the aortic aneurysm, abdominal aortic aneurysm. So they either have a weakening or a thinning there, and it's become very large. And when they lay back, you can see it pulsate with their pulse, basically. And some people walk around with this. They know they have an aneurysm and it hasn't been significant enough for them to treat it. But if you see that pulsating mass and they're having low blood pressure, complaining of tearing sensation or pain in their back, that aortic aneurysm is probably weak. So it's not a good thing. It's got a very high mortality rate. But so when you've got them laying down and you're looking at that belly, look for any of those pulsating masses and it should be right in there. That distension, it's like the Pillsbury Doughboy. He's about done there with the belly button hanging out. But you know, that's a firm belly. I can, you know, just looking at it, that's firm. But when you go to push on it, if you can't, like again, belly should be soft and you should be able to palpate pretty far in there. But when they've got distension, whether it's from fluid like blood or GI, maybe they got some kind of GI issue where contents are leaking somewhere, or they have infection. If they've got, or just air, maybe they have free air in there. When you go to push on their belly, it's going to be like extremely firm. You're not going to be able to push down. And these people are very uncomfortable and like, ouch, ouch. Because it's extremely stretched out nerves, all that kind of stuff. So the distension is important. When you see distension too, this doesn't have to do with trauma, but if you have a cardiac arrest patient and maybe bystanders were doing CPR and they were doing mouth to mouth and they're giving air too much, too fast, that air will bypass and will go into the belly. So it's going to go into the esophagus versus the belly. and you get this big old belly on people and it's full of air. And unfortunately, what goes in must come out at some point, and they could start vomiting. And that's where we get our messy airways a lot, because that's just a side note on CPR. But you will see that a lot when you go to somebody who's had bystander CPR, and sometimes even untrained or unfamiliar CPR trained people that just haven't done it before. You'll see this. But that, anyway, so back to trauma. So you're going to check 4 quadrants. So basically you are dividing the belly button into 4 quadrants. So you're going to check that top, you're going to check the next top, and check the bottom, and then your right bottom. And again, you're looking for any kind of pain response, and if it's soft or firm. Rapid assessment of the pelvis. Again, we're looking for bleeding, priapism, which is erection, but it's due to spinal injury, and or vaginal bleeding, urinary or bowel, fecal incontinence. So when you're looking at pelvis, it's not just for injury, you're looking for signs of trauma. So all these things could be happening down in the pelvic area. When we check the pelvis, these things like unstone, but when you're checking pelvis for injuries, what you're gonna do is you're gonna come over and you're gonna hold on to the pelvic girdle up here in the pelvic, and you're gonna push in on both sides evenly, and then you're gonna push down. You don't walk it, you just push in. For any signs of movement, your pelvis shouldn't move. So if you're feeling movement though, or if people, like, oh, it hurts. Okay, so we have pain on pressure, and we're putting pressure in, and then we're going to push down because we're checking that stability of that pelvis. It should not move. So the old way people used to walk it, but again, if you got a spinal injury, you got a pelvis injury, start moving that stuff around, you could increase bleeding, which cause more trauma from that. So it's a pressure in and a pressure down. From the pelvis, we're gonna check our extremities. I usually do lower extremities first because you can lose a lot of blood through the femur fracture. We talked about that last week. Or from, a puncture or penetrated trauma to an area, the femoral artery. So I'm gonna check, look for any wounds, bleeding, tenderness, deformities. And then when I get down to the foot, I'm looking for circulation, sensation, and motor function. So I'm gonna look for a pulse, fetal pulse, and then can they feel my touch and where are they feeling it? And then have them wiggle their toes. So that will tell me that they have circulation, sensation, and motor function. So we're gonna ask them again, can you feel me touching you? Where am I touching you? And can you move your big toe on your left foot or whatever? And then you're going to do the arms after that. And the same thing on the arms. You can feel the arm, looking for your BTLS, and you're going to check for your motor, sensory, and circulation. Let's go ahead and take a 5-minute break, 10-minute break.
Girl, I just appreciate you.
Thank you.
Just so you
Hey, I just don't care for these slides. I have a. All right, let's
Oh, I gotta click back on here. Okay, there you go. Should be good.
That's some IPI.
Okay, so we talked about CMS. Obviously, we did lower extremities. We're doing our upper extremities, same thing. We're gonna check for radial pulses, check for sensation, movement. And we could do this for a full trauma, or if they just complained, they fell and they hurt their arm, we're gonna check CMS. So, we're gonna look for that pulse, and movement and sensation. Motor function, again, that strength in hands by asking patient to squeeze fingers. We're looking for that symmetry. Do we have one side that's weaker than the other? Or do we have one side that doesn't move at all? Versus, you know, if we look at strokes and those type of things. And the pulses.
I do like that one picture back there. You don't have to go back to it,
Which
but this one.
Yeah.
Because they're squeezing both fingers. A lot of times you'll see someone just grab one hand, squeeze my hand, I'll squeeze my hand. You're not gonna be able to tell the symmetry. So it's important to have them squeeze both hands at the same time.
So once we have done, our extremities, this is where we roll the patient, up on their side. And again, someone's holding C-spine, and so, we're gonna move the person as a unit, that person's still holding C-spine, and then we've gotta assess, the backside. So, while you're doing that, the other people can be, pushing a backboard, under that patient. So when you're done with your assessment, you just roll them right back onto the backboard. But you've got them up on their side, so what you wanna do is you wanna check their back. So you're gonna run your fingers down their spine. What are you looking for? Formies?
Abrasions, laceration. Penetration. Penetration.
Not money if you win.
Burns. Change.
Tenderness?
Tenderness,
Tenderness,
lacerations. And we say temperature, so swelling.
Well.
That's not a part of it.
Nope. Okay. So some of the things we look for when you're running your hand down their spine is you're looking for what we call step offs, those deformities. So if you've got a major step off and you have patients complaining of, I can't feel my legs or whatever. So if you have those type of deformities, obviously want to note that where you felt that. But again, you're looking, yep, you're checking your kneecap, UTLS, and then you're going to roll the patient as a unit, full unit back over to the backboard, and then you're going to secure them to that backboard. Then you're going to obtain your vitals, your blood pressure, pulse, and respiratory rate, pulse oximeter if you can, and that's when you start your medical history. So this assessment, this head to toe, really shouldn't take you very long. Like this is a rapid, you're just looking for anything major at this point. And when you push or press on something, you're palpating it and they go out, you remember that, you're gonna go back to that, and you're gonna reassess it when she gets back to it. But this is to get them moving, that you can say, yep, I did an assessment on the back, I didn't see any injuries. I didn't feel anything, the patient didn't say anything that hurt, so when we get to the ER and they're like, was there any injuries on the back, you can say, no, because I assessed my patient, I didn't see anything. Or you could say, yes, I felt a deformity, you know, around the T3, T4 area, with pain, and they have that in their lower extremities. So again, don't forget the backside, okay? So that's what that looks like. Again, you've got that person holding C-spine. You've got multiple people holding, and you'll be palpating here. So again, you're going to be running your hand down their spine. You're going to be checking their flanks, under the armpits if you didn't, like maybe back here, because if people are laying, you're not going to necessarily feel that. If you get a visual on that as well. And then again, you've got to check buttocks and the back sides of legs, back sides of arms, and then go ahead and roll them over to the backboard. Make sure you're talking to your patient. Let them know what you're doing. Expose injury area before examining it. That's again, we want to, trauma patients, gotta get their clothes cut off. That's why we hear the cancer scissors. Get it off so you can visualize what you're examining. Maintain eye contact as much as possible. These people, if you've got them strapped to a backboard and you're talking to them, remember they can't look at you. Like all they can see is right here and maybe a little peripheral. So, you know, bend over them and talk to them. But make sure that you maintain their people. Make sure you maintain that eye contact with them. Final protocols again, know your protocol wherever you work. And so if you have, so you go to a gunshot wound and you did your assessment real quick. You've done your head, neck, chest, and then you know, they complain, and you can see that they've been shot maybe center chest, maybe a little lower, I guess. We'll go lower. So maybe right about here they've been shot. And so you can see that entrance wound, and you roll them over, and you see an exit. So if we got major bleeding, we're going to stop right there, right? Because we got to go back to what? So if we have, you know, if you've gotten to this point, maybe they had a lot of clothes on because it's winter time and you didn't see that blood at first and you're doing your assessment and you get to that point, you're like, oh crap, that's why you hurt. You know, so you cut their clothes off and you're looking and you see that entrance. We obviously got to look for that exit wound, but we're going to stop and we're going to deal with that blood loss right there. So we might not get to the extremities right there because we're back to ABC. Or if we get to airway and you've got a flail segment, like they can't breathe. They're not breathing appropriately. So they're taking that deep breath and you've got that one weird section that's kind of doing what it's not supposed to be doing. And so we're going to stop and we're going to treat that because that's ABC, right? So that's your breathing and respiration. So if you've got somebody who was in a car crash and the airbags deployed, and maybe they have multiple fractures in their face from the airbag and hitting the steering wheel, and you get them backboard, you get them on their back, and they have blood in their airway, and it's starting to drain. So what do we got to do? We got to clear that with airway. So we're stuck at airway. So again, if you've got anything that you've got to stop to treat for major bleeds, it's kind of like, okay, yeah, any of your ABCs, we got to stop, we got to treat. After that, once we get them in the ambulance, we're going to come back and do that detailed work. We can splint the broken wrist or you know, ankle or whatever. But that's not life threatening. So we're not going to stop our assessment for that. We'll know to come back. So your pediatric examination, again, usually you start at the feet, but here they go from your head. So when you're looking at the head, you guys know what the fontanelles are. So in an infant, in a young toddler, their fontanelles aren't closed, so the sutures in the brain or in the skull hasn't closed all the way. So there's a soft spot in there. So we don't want to be, when we're doing that assessment, obviously sticking our fingers or pushing into that soft spot. If as you are doing your assessment and you feel a bulge in that soft spot, that could be indicative of some swelling in the brain. So that's the one difference with the skull on adults versus children or infants. And collisions, again, we talked about this last week. What's the biggest part of the toddler's body? That head. So anything, any kind of fall, any kind of trauma like that, they could have that head. That usually is what goes first, is their head. Nose and ears, same thing. You're looking for blood, any clear fluids coming out. Mucus or blood clot obstructions can disrupt breathing. Again, their airways are very small, and so anything minor that we could probably pass with a cough might cause an obstruction in there. So your assessment really doesn't change. You just got to remember there are some differences as far as their body size and proportions. You're, again, going back to that head is larger, so spinal cord injury is greater because you have a lot more weight per body size. So again, that motion, you've got more mass. So again, mass and what? Speed equals higher mechanism. So, and kiddos can have spinal injuries, well, anybody can have spinal injury without a fracture. So if you're not feeling it, an injury or crepitus, deformity, if you're not feeling it, but they're complaining of numbness, tingling, that kind of stuff, again, don't rule that out just because you don't feel it. And we don't have x-ray vision, so we are going to treat as is. Look at your mechanism, look at the complaint. Airway, keep infant's head in neutral position, keep child's head in neutral plus or sniffing position. So the difference in the infant's airway is, so if you feel your trachea, you can feel your trachea here, and if you slide your fingers back forth, you can feel that cartilage rings. And that's what keeps your trachea open, like I can do this, and my trachea stays open. In an infant, their trachea doesn't form, and it's kind of like a straw. So if you have their head too far forward, think of kinking that straw. And if you have their head too far back, think of it flattening out the straw. So we keep their head in a neutral position. So it's just barely, barely up. And infants are, if you're dealing with airway issues, are just a whole other nightmare. I'm going to tell you that straight up front because of the positional problem, and then their airways are so small. And so that is a challenge, even as a medic. If I've got an airway issue in an infant, your stress levels here, and then you're dealing with small components. So, but again, that head position is really critical. And the neutral plus or sniffing position, I tell people, I said, think about, you come home tonight and someone just made chocolate chip cookies. What do you normally do? That's the sniffing position. It's not much. It's not much of a movement, but it's just barely moving that head up. And that's just, it's just slightly above a neutral position. If you, hopefully you never have to, maybe you'll be one of the lucky ones that doesn't have to deal with messing with the airways. But just remember that they don't have those cartilage rings to keep that trachea open. So you're the one that's going to be doing that for them. You've got to keep that head neutral. Chest, check for even breath sounds. Listening to infant lungs is very difficult because it's a very small space. Sound in an infant's chest, it's really hard to tell what side it's coming from. You might just hear that you have lung sound, but you can't pinpoint where exactly they're coming from. Again, I like the back. I like checking the back even on infants. It's just a little bit harder again if you've got a trauma and you're dealing with infants, but the breath sounds are going to be difficult, but you should be able to hear them. You just can't pinpoint where, if it's upper lobe, lower lobe. Again, if you've got an infant, their lungs are about that big. So check for symmetry, bruising, paradoxal movement, and retraction. So symmetry, again, do they have equal chest rise? Are both lungs expanding and their chest is rising, and is it falling at the same time? Any bruising to that chest area. Paradox of movement, again, are we looking at one side is not moving, or do we have a flail segment of their ribs that are is broken and they have that paradox of movement? And retraction. So retraction is if they've got difficulty breathing, that they're using accessory muscles in their chest wall to help them breathe. So if you're seeing that that retraction of the muscles in their chest wall, also babies are belly breathers. So if you've got a 3-month-old, watch that belly too, because they're belly breathers. So you're gonna have to, and then as they get older, they become more chest breathers. But watch both the belly and the chest for that retraction, because they'll use the muscles in their abdomen as well to breathe if they're at that point where they're struggling to get that breath. Abdomen, not rigid or tender. Areas of distension. Again, in an infant, you might, as you press, they might cry. But if this is a trauma, you might not get that reaction. They might be already crying, and it's really hard to tell if a 3-month-old has a belly. But what you're looking for is the distension, firmness, softness. And again, you're still doing those 4 quadrants. They're pretty good. So you might use 2 fingers versus a whole hand. Injury that impedes movement of diaphragm can compromise breathing. Yeah, I mean, diaphragmatic injuries, that's what helps move air out of your lungs. So when we have a, simplified, you have a choking infant or a toddler. When you give your abdominal thrust, what are you doing? Because we're all CPR certified, right? So what are we trying to do? When you're giving abdominal thrust, and you've got a toddler, you're around here, and you are pushing up, what are we doing? Okay, so when you cough, what does your diaphragm do? Comes up. So when you're given an abdominal thrust, you're trying to mimic the cough and push that diaphragm up, because it will compress the lungs and hopefully spit out whatever. But if you've got injury that you no longer have that mechanism where your diaphragm is moving, is that kiddo going to be moving in air? Probably not. Probably not a whole lot. So again, if this is a respiratory, this is a trauma that caused a respiratory issue in an infant, and they're not moving air, and you're trying to bag them, and you're not getting a lot of air in. Think about the mechanism, and if they have possibly a diaphragmatic injury. I mean, you're not going to be able to tell per se, but just keep that in the back of your mind. That could be, and if they've got distension in the abdomen as well. But again, your diaphragm is what moves your air. If you take that deep breath, your diaphragm pulls, and your muscles, everything pulls, and when you blow out, your diaphragm comes up and is pushing air out. So if your diaphragm's not working, it's not moving air. Your pelvis, again, in there's a pause there. All right, so pelvis stability, again, press and push, don't rock the girdle. And then even in a child or an infant, when you're doing that pelvic exam, it shouldn't move. So when you're pressing and pushing, there shouldn't be any kind of movement there. Extremities, capillary refill, less than 2 seconds, poor peripheral perfusion or dehydration, distal pulses. So cap refill. So basically, you go ahead and take your finger. I don't know if you guys ever done cap refill before, but you might not be able to see yours because you have nail polish. But You can just skin alone. If you press down for about 5 to 10 seconds and release, that blood should come back. So you're gonna blanch it so it's white and push down and then you're gonna let go. So it should come back to pink and normal in about 2 seconds. If it's delayed, then we gotta know why. And it could be, maybe they're just cold. But if it's a trauma situation, do I have a perfusion issue? And could that be to hypovolemia or hypovolemic shock? So I'm not getting that, or is it, do I have a sick kid and they're dehydrated? So, and in adults, it's the same thing. So it's less than 2 seconds is normal. If it's delayed, we got to figure out what's going on. Very simple. So very simple thing to do. Extremities, we're going to look for painful, swollen, and deformed injuries. And again, there's your extremities, your pulses in infants. You're not going to get a radial pulse. The smaller they are, you can do a brachial pulse. But again, if you're looking for that circulation, it's best to do the cap refill. So you're looking again at circulation, you're not going to get that radial. So that's one of the reasons, like when I go back to this slide, they talk about the cap refill versus checking. You can, like on a foot, you should be able to catch that pulse, but on the radial pulse, it's very difficult. And I don't know if my little videos didn't work last time, but let's see.
Hey everyone, it's Sarah, registered nurse RN.com, and in this video, I'm going to demonstrate how to perform the capillary refill test. The capillary refill test, also known as capillary refill time or nail blanch test, is a simple technique nurses can use to check peripheral perfusion or for dehydration. So how do you perform the capillary refill test? It's performed by pressing on the nail plate or the pad of a digit for around 5 to 10 seconds, causing the nail bed or the pad of the digit to lighten in color as the blood is expelled. Then the nurse releases the digit and observes the number of seconds it takes for the tissue to regain its natural color as blood flow returns. And it's important to note that sometimes the capillary refill test is actually performed on the sternum or the forehead in some patient populations, such as newborns. Now, what is considered a normal versus abnormal capillary refill time? Well, typically, if the blood returns to the tissue within 2 seconds, that's considered normal. So if it takes longer than 2 seconds, that's abnormal and should be reported immediately. However, some studies suggest that a normal capillary refill time could be up to 3 seconds in certain populations. Therefore, always refer to your facility's guidelines for this time range. Now, what could cause an abnormal capillary refill test in a patient? Well, when a patient's experiencing poor peripheral perfusion, where there's limited blood flow going to those extremities, or even dehydration. And some common examples that could cause poor peripheral perfusion include decreased cardiac output, and this may be due to shock, heart failure, anemia, or other similar conditions, bone fractures, where compartment syndrome is presenting, and this is where there's a restriction of blood flow in the affected limb. Cast care and placement. If a cast is placed on a broken limb, capillary refill is often assessed to ensure that proper blood flow is reaching the extremity and that the cast is not too tight. Peripheral vascular disease, and this is the narrowing of vessels that can reduce tissue perfusion. Raynaud's disease, this can cause vessels to spasm and narrow in extremities that are exposed to cold, which reduces blood flow. And then finally, hypothermia. In addition, some factors can affect the reliability of the capillary refill test and lead to longer capillary refill times, such as cold temperatures, edema, swelling in those extremities, old age, and smoking. Now let me demonstrate how to perform the capillary refill test on a fingernail. First, you want to perform hand hygiene. Then you want to greet the patient, explain the procedure, and obtain consent. Then
so when you get into your splinting area, you're going to be doing cap refill. Like if you splint from your field, you're going to be reassessing the cap refill because if you have splinted and it's too tight, that capillary flow may decrease, so you might have to issue. If, again, if you're, treating a trauma patient and they have good capillary flow on the scene and 15 minutes later you reassess and they don't, what changed? What do we need to, we have to go back and reassess. Is it a local injury or is it systemic? All right, so what criteria would you use to decide whether to perform a focused physical exam or a rapid trauma exam? So this is on a, let's just say, you're dispatched to a fall, and it's a 80-year-old female who just tripped on her oxygen cord and fell. So she's complaining of hip pain. So would we, what criteria would we use to decide whether or not we're going to do a focused physical exam or a rapid trauma? The what? Severity of the wound. Okay. What else? So think from the very beginning when we started last week. What is your mechanism of injury? So what is it? Fall from height. But she's 80. So what does that do? That increases the possibility of having a more severe injury. We talked about pediatrics and old people. We always got to up it a little bit. And so we have a higher mechanism for her. She's complaining of hip pain. Did she complain of anything else? No. So you get there and you ask her those questions. Past medical history, she's on oxygen. As you're looking at her, her skin is warm, pink, and dry. What else do we need to know? Sample. But at this point, like you're trying to decide, is this a load and go, or do we have time to do a full assessment, a focused assessment, I'm sorry, on the injury? So what do we need to know? How about we start at, okay, so we did mechanism. Is she alert and oriented? So we go through what? Output? So before that.
Just where knowing those sheets comes in handy.
Okay.
Just
So basically, we're trying to decide if this is a load and go. Is this a emergent? We need to get this lady going because she's gonna die right here. So what tells you that she's
alert.
warm, pink, and dry? She's alert. She's talking to you because my hip hurts.
Circulation, you can check that out.
So we can slow this down and go to that probably focused physical exam. So if you get there and she fell and she's unresponsive, changes things, right? So, yeah, so we would start doing that rapid trauma because we don't know what's going on with her. What did she hit? Did she fall on top of her head, or did she go unresponsive and then fall again? So we're going to do that rapid trauma exam. And again, it's the ADCs and your cabs and your APTUs. I know there's a lot to like figure out where all this stuff goes, but remember what's life threatening, what's not. And if you try and stay in those lanes, and if anything life threatening rears its head again, we go right back to that. So if grandma says it's just my hip, and you get on the back of the rig and you get her squared away, and then all of a sudden you look over and grandma's like pale and she's not responsive, and her blood pressure just took a crap. We're gonna go up. We're gonna move her to let's get moving type thing. So she'll go back into the emergent category, and we're gonna concentrate on those ABCs. And we might have to do then a rapid trauma because we're doing this. So it's fluid. You gotta watch it. It's constantly, looking at your patient, and, things could change from stable to unstable to unstable to stable. So it's not just getting them in the back of the ambulance, it continues. So your detailed physical exam, so again, we just did the rapid, you're just doing a quick palpate, and, getting them on a backboard in the back of the ambulance. And now we can go back to that arm hurts. It's one of those things we're gonna go back and look at. So, this is where you're gonna gather that additional information, either about the medical issue or the trauma. And then it'll help determine what you're going to do to treat the patient and what will assist the emergency staff on arrival. And this is performed most often on trauma patients with significant injuries. So again, it's really easy for us to get distracted by that gross pool trauma, that traumatic fractured, open fractured leg or whatever. It's so easy to be like right there, but you've got to remember you have the whole rest of the body. So we're gonna have to go back and look at that. So for these patients, you'll have assessed almost the entire body during the rapid trauma, but now you gotta go back and do a more thorough job. And part of this is that reevaluation. So you did that rapid, but now we're gonna go back and we're gonna slow things down and really take a look. But it's a good reevaluation of them. You only perform the detailed after you've performed all critical interventions. So again, we treat all the things that are going to kill them first, right? So airway, breathing, circulation. So we treated those, and now we're going to go back and do the detailed assessment, and then we will splint that broken arm or that finger or whatever. Or if it's a small laceration that's kind of oozing blood, we can go back and bandage that. But that's not the primary concern. We're not going to leave that from that. Okay, so, well, eventually they would, but not right there. If you are treating a severely injured patient and are too busy to complete the detailed exam, it's not a failure. It's your responsibility to give the patient the best care possible, which may mean skipping the exam in order to maintain airway, breathing, and circulation. You may never leave that. You might not get a full exam. It's just, that's the way it is. Our job is to keep them, is to treat their major injury and get them to the hospital. And if we've got an airway or breathing problem, that's where we stay. And we are not going to worry about that deformed lower leg or that ankle or that arm. We might not get there because you'll have one or two people in the back, depending on where you're at and where you're at. And Glen Rock a lot, you're by yourself. And so I may be sitting there begging a patient and I don't get anything else done, just the way it is. So if you have more than one person, that's when you start assigning things and then you guys can work as a team. But when you do your detailed, you're obviously, if you haven't already, you're going to expose the patient again, cut those clothes off. Noise and motion may interfere with some procedures. So try and get your lung sounds before you get down the road. You're going to have to reevaluate, but this is where you want to spend the money on a good stethoscope. It's easy to go to Walmart, get the $20 one. I'm telling you, invest in a good one because you will be able to hear. I mean, I've lived for 5 years and I could hear lung sounds with my good like that. And it's been with me for almost 30 years. So invest in a good stethoscope. But you still will get interference at some level. But motion as well. I don't know if you've ever tried to do CPR in the back of an ambulance while somebody's driving code that really doesn't drive ambulance. It sucks. So
Especially when they hit the railroad tracks.
yes. Or you're trying to intubate and you're getting tossed around. So there are some things, sometimes you just have to say, we need to pull over real quick and I need to do this real quick. And then you get moving. So don't be afraid to be the boss and say, you know, I'm not hearing alarm sounds, we gotta stop for a second so I can assess this real quick. And then, or you're getting thrown around back there, don't be afraid to tell somebody, hey, slow down. Because you have to get there in one piece and you've got to be able to treat the patient. Work around immobilization equipment. So if you got somebody backboarded and all of a sudden they feel nauseous and they got to puke, kind of a pain in the ass. You got them backboarded and then they're strapped to the cot, so they're completely flat. So this is something you will real quick, very, very quickly. You're gonna learn how to get those things off and get that patient to their side. So otherwise you're gonna have an airway issue. So working around what you just treated, or, you know, like again, you go back and you check CMS in your reassessment and you're not getting good cap refill after you splinted. And now you've got to go back and you got to re-splint, you know, loosen it up and re-splint. Or you've just splinted their whole arm and you maybe covered up, maybe they had some lacerations or whatever, so you covered up their pulse. So now you got to figure out, okay, how do I get to their pulse on that arm? So do we need to cut things or do something different to be able to assess that appendage or back or whatever you're doing? But you have to work around what you've treated. Components similar to rapid trauma exam, it's just this is slow. You have time to take your time to do this. The rapid is just to point the major injuries, and then we're going to go back, and it's slow and a little bit more methodical on the details. So it's kind of repeating, but you're slowing down, and you're treating as you go. So trauma patient who is seriously not injured generally doesn't need a detailed physical exam. So again, that trip and fall and they hurt their hip and that's the only thing they're complaining of, and you're not seeing any signs and symptoms of them being unstable, we're going to treat that injury as it's just a focused injury. We're not going to do the full head to toe unless we see something change in our treatment or in the patient, and then our treatment will change. Again, we can throw in a detailed physical exam if our patient starts to come. We got to figure out what else is going on. We're going to go back to our reassessment, and then we're going to come back again and look, did we miss something? Keep a high index of suspicion. When in doubt, perform a detailed physical exam. Be aware of patient's fear and need for emotional support. Most people don't ride an ambulance, I mean, under the best circumstances. So anxiety is definitely there. We talked about your initial assessment on a car crash, or if they've been shot or something traumatic happens to them, what is their pulse going to be? Going to be elevated. What's their blood pressure probably initially going to be elevated, because that's our body's response to stressors. Again, that reassessment, again, you got that baseline, it's blood pressure's high, pulse is high. 15 minutes later, when you go to reassess, it should come down. It should start coming down, but you don't want to obviously to come down too much if it's a trauma. So you're kind of, like I said, that constant reassessment, and then talking to your patient, letting them know what you're doing. Sometimes while you're doing it, again, keep it simple. Is it necessary to always complete a detailed assessment on a trauma patient with no significant mechanism of injury? So they're just asking what I just told you. So grandma who fell just has a hip pain. We're not going to spend a whole lot of time doing a detailed assessment if that's the only thing she's complaining of, and you're seeing signs and symptoms of a hip injury. But that in that reassessment phase, if we're starting to see other things, then we can always go back and do that. All right, so the patient without a significant mechanism of injury receives a history of the present illness and physical exam focused on areas that the patient complains about, and areas what you think may be injured based on the mechanism of injury. So keep it simple. Don't make this more complicated. I know a lot, like I said, we're throwing a lot at you, and until you start getting kind of a system down, it's really hard to understand what we're saying. But If someone it's simple, they tripped and fell and they're complaining of an arm injury. Or, you know, they fall and maybe one of these and their wrist hurts. Do we necessarily have to go through all the full exam? No, because they're stable and they're just complaining of a pinpoint injury, which falls in line with the mechanism. Next, gather a set of baseline vitals and a past medical history. So you're always going to do your medical history. Your sample is part of every patient you contact. So that just becomes part of but it's not an emergent thing. Okay, so if you're treating an ABC, we're not worried about sample history yet. It's great if you can gather that stuff, but this is afterwards. So you get your medical history and baseline vitals. For the patient with significant injury or mechanism of injury, provide spinal precautions, consider whether to call advanced life support, get a brief patient history, and perform rapid trauma assessment. In a rapid trauma assessment, look for wounds, tenderness, deformities, your DCAP, BTLS, plus certain additional signs appropriate to the part being assessed. Systematically examine the head, neck, chest, abdomen, pelvis, extremities, and posterior body. After assessing the neck, it may be appropriate to apply a cervical collar. After completing the physical assessment, provide spine motion restrictions and get a baseline set of vital signs and past medical history. So again, terms have changed. Spinal mobilization or spine motion restrictions. So basically you're holding C-spine or putting that collar on, depending on the protocol, you know, or you do the full backboard or you just putting your collar on, but you are assessing that. And we've kind of beat this one again. You're going to do that critical intervention for your life-threatening injuries. And then when you're in transport, then you can go back and do your detailed if you've stabilized your patient. Detailed physical exam is similar to the rapid trauma assessment, but there's time to be more thorough in the assessment. The detailed physical exam does not take place before transport unless transport is delayed. So what they're talking about there is maybe you're waiting for life flight and you have time and you're rendezvousing with, you know, a quick behind somewhere. And so you have the patient in the back, you have that time to do that, but normally you wouldn't, you would just transfer the patient over. But the detailed physical exam is the most appropriate for the trauma patient who is unresponsive or has a significant injury or unknown mechanism of injury. A responsive trauma patient with no significant injury or MOI will seldom require a detailed physical exam. So someone who's able to tell you what's wrong, usually you don't have to go into that because they can say, my arm hurts, my leg hurts, whatever hurts. And you can focus on that. Use mechanism or injury to determine the need for rapid trauma assessment. Assume spinal injury and work as a team to complete the assessment. And we don't have x-ray vision, and I have had people have some crazy spinal injuries or fractures that they didn't complain of, but the mechanism was there. And so we've got to, like I said, we're putting those pieces of the puzzle together as we're from the moment you're dispatched to your response, to getting on scene, gathering those pieces, to your initial look at the patient, and then when you start building on questions and getting your hands on doing assessments. Do the focused physical exam of a trauma patient with significant mechanism of injury differ from those for a trauma patient with no significant injury? We talked about that. List the steps and areas covered in the rapid trauma assessment. How are these steps different in detail? So again, it's One is rapid, you're doing a quick sweep, basically looking for major injury. The other one, we're inspecting a little bit detail and fixing the small things, so that fractured arm. Okay, critical thinking. You are assessing a patient who fell 3 stories. He is unresponsive and bleeding in his airway. The driver of the ambulance is positioning the vehicle and bringing equipment to you. So let's go back to your initial dispatch. The patient or a person who fell 3 stories. Dispatch info, unresponsive and airway issue. You get there. What is your first, what do you need to do first?
Airway.
Team safety,
Airway.
BSI. How many patients? You need who coming? DLS or other resources? Okay. And then what? Now we can go to. Okay. So, and what should you be able to tell as you're looking at the patient, just walking up to him?
Conscious.
Awake, yeah, if they're conscious. Are they moving around? What is their skin color? Do you see any major bleeding anywhere?
Noticing bystanders.
Yeah, see the bystanders, you can start asking, where did they fall from? Because you don't really know, besides what, especially that somebody probably seen it.
Look at the fall on your side of
Yep. Did they, what did we talk about falls? Did they
it. It's
all the way down? And then what did they fall on? What kind of, ground did they fall on? And as you're walking up, you see that there's, blood, in his airway. So what issue do we have? An airway issue, okay, so, what do you think we need to do? Suction. So get your suction ready, and you're going to try and keep that airway patent. So you're, maybe got your bag with you, and so you have your portable suction. So you're doing that, you'll learn how to do that later, but you're gonna be doing that. What equipment does your partner need to bring to you? What do you think? Backboard, seat collar, and hopefully some help. So again, if he's unresponsive and he continues to bleed into his airway, what kind of assessment are we gonna do? Yeah, you're stuck on your ABCs, you're stuck on that airway, because his airway is not clean.
I was waiting for the trick question. I'm on to you.
And here's that top. So how do you balance that? How do you balance, if he has a constant airway issue, but you also need to figure out what other injuries does he have? What is your
Airway.
So
Once help, once more people are.
absolutely.
Yeah.
So you can hopefully have somebody who knows how to suction a patient or knows how to assess a patient, and they can surely help you out. Because the other thing we got to look at is you're bringing C-spine precautions or equipment with you, but you've got to take C-spine. So your C-spine and your airway. So your hands are full. Like that sucks. You're there. So
The airway injury might not like to use.
yeah, it might not. So, you guys have any questions? I know a lot of that is dry until you actually like, it's hard to assess patients through PowerPoint. But-
Yeah.
You guys have any questions or any issues with that?
Tomorrow, it sounds like we'll do the hands-on, start